Good evening and welcome to all to Asthma in Spring, Allergies and Thunderstorms. I'm very pleased to be helping facilitate this event. My name's Marie and I sit in the primary care support team. Before we get started, Northwestern Melbourne Primary Health Network and myself would like to acknowledge the people of the Kulin Nation, as the traditional custodians on the lands in which our work today takes place. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. A little bit of housekeeping before we get started for this evening. All attendees, if you wouldn't mind keeping your microphones on mute, I believe that helps with some feedback issues for the presenter, and Jen, who's in the background helping me along from PHN as well. And we'll also have, if you can pop your questions in as we go along into the question box, and Mark has just informed me that we'll have two opportunities for questions, one at about halfway mark, and then we'll take some more questions at the end. So feel free to pop those into the question box as you come across them. Before we get into this evening's asthma education, I'll just take you through 4 quick slides on what's upcoming at the PHN, the think tank, COVID update, and of course, number 4 is our asthma ed with Mark tonight. So the upcoming education and training, as you can see, it's a pretty busy calendar for October and running into November. We've got kidney health on the 7th of October. We've got a really important topic on family violence on the 8th of October, if anybody's available for that. Wound management, there's 2 of those sessions on the 13th and the 15th of October, and that should be a cracker with Jan Rice, and that's at the practice nurse meeting. So if anybody has their practice nurses there, give them a nudge. We've got on the 13th of October, the residential aged care statewide COVID response. And then, of course, with the asthma running on from today's topic, on the 22nd of October is the food allergies and constipation in paediatric patients. And of course, 10th of November finishes the calendar for a little while on the asthma medications and devices. The thing, if ever you were wondering how to get involved with the PHN, join the think tank. It's a great way to hear about opportunities as wider an interest range from practice management, human resources, quality improvement, diabetes, mental health, and lots more, as you can see there. The 4 very important S's for COVID-19: staying up to date with the DHHS website, sign up to the PHN updates and e-blasts, subscribe to the Victorian Chief Health Officer's alerts, and save the hotline number for the DHHS communicable disease section. And moving along, there is a pathway for that. Our Melbourne Health Pathways, oops, sorry, I've just jumped ahead there. That's a growing area of interest, and clinical assist with the pathways. And if you want a direct, you can contact Melbourne Health Pathways and they'll organise a request access for your whole team, your whole clinical team. And now I'd like to give a very warm welcome to our speaker tonight, Mark Gordon. Mark has worked for many years in primary care, and in the last 14 years, firstly as a practice nurse, so she's got a fabulous understanding of the primary care sector, and for the past 14 years as an asthma and respiratory educator. She currently operates nurse-led respiratory clinics in 2 practices in eastern Melbourne, And this allows Mark to work closely with GPs to provide evidence-based best practice asthma management in the community. Mark also works at the National Asthma Council of Australia as a project manager for the Asthma Best Practice Program. And this provides education courses to health professionals around Australia. So with that being said, I'd like to very warmly welcome and hand over to Mark.
I'll just set this up. Sorry everyone, I'll just take a minute and get that on full screen for you. There we go. Okay, thank you so much for that warm welcome, and thanks to Northwestern Melbourne PHN for hosting tonight's event. I always shudder when I look at that introduction, because you forget about how many years you've worked in a particular area. So that's a bit of a harsh reminder for me. Anyway, tonight we're here to talk about asthma in spring, allergies and thunderstorms, and it's a great time to be doing that because we've had the gamut of weather in Melbourne in the last few days, haven't we, with hot, blustery wind and then a sudden cold snap. So it's a great time to be approaching this topic. As we said, we've got questions as we go along, so we'll like to keep these nice and interactive, and if you do have your questions, please send them through. So tonight we're just going to be looking at the association between allergic rhinitis and asthma, and we'll be summarising the treatment guidelines for allergic rhinitis. It is a really big topic, but we'll do our best to cover it thoroughly tonight. And the second half of the presentation we'll be looking at thunderstorm asthma, what that is, what it means, and the guidelines for management. And then ending off with the importance of the written asthma action plans and first aid for the thunderstorm asthma season. So just to set the groundwork, and I always like to put a few stats in so that we realise the importance of the topics we're talking about 15% of Australians have allergic rhinitis, or hay fever as it's commonly called, in the community. And we've got about 10% of our Australian community that have asthma, and these two conditions often go hand in hand, and I'll be talking about that as we go through today. Allergic rhinitis, though, is often underdiagnosed, undertreated, and suboptimally self-treated. And that can be said for asthma in some cases as well, particularly those with mild asthma. So what I mean by that is that the symptoms of allergic rhinitis, people just tend to tolerate them. You know, they might know they've got it. Yes, it's a bit irritating, got a scratchy throat, got a bit of a runny nose, or whatever it might be. So they either don't bother doing much about it, or they treat it ineffectually, which doesn't help their allergic rhinitis or their asthma if they've got asthma. Allergic rhinitis is most common between the ages of 15 and 54 years old. I've no idea why that is, but I know in my clinics I certainly see some kids a lot younger than that that have got significant allergic rhinitis, and I'm sure you'd be aware of that as well. Most people that have allergic rhinitis are actually sensitive to quite a range of allergens, and this can make the condition more frustrating for them, and it can also make it a little more challenging to treat. And we do speak about the United Airways disease, and it's, if you like to think of it as just really the upper airway, which is, you know, the nose and mouth and sinuses, and then the lower airway, which is from the trachea down to the lungs. And we always understand that asthma is an inflammatory condition of those bronchioles, the small airways of the lungs. And in fact, in allergic rhinitis, is the same inflammatory response to the epithelial lining within the nose and the sinus cavities. And that's why we call that a United Airways disease. It's upper and lower airway inflammation that's going on. Allergic rhinitis is an independent risk factor for asthma in children and adults, and the presence of both conditions is associated with worse asthma control. So it increases the risk of a more severe asthma flare-up if you have both conditions and one or other or both of them are not managed as well. So 50 to 80% of people with asthma also have allergic rhinitis, and 20 to 30% of those with allergic rhinitis have asthma. And we need to remember to treat both conditions. So when we think about assessing allergic rhinitis, you know, we always talk about taking a thorough history for any medical condition, and it's no different with allergic rhinitis. So we would ask people what their symptoms are and how severe and the frequency of those symptoms as a start. So the common symptoms that people would be very aware of are itchy, watery eyes, the runny nose, sneezing, the constant throat clearing, tickly throat, which I've actually got today from my rhinitis, frequent sore throats. They can be snorers because of the inflammation in their nasal passages, and they may even mouth breathe, and particularly kids will mouth breathe, as you would know. So the frequency of the symptoms can sometimes be seasonal or sometimes perennial. And seasonal allergic rhinitis can happen at any time of the year, but is more common in spring, summer, because there are a lot more allergens around. So there's a lot more grasses, there's a lot more flowers that come out. There's, you know, the wattles come, the pollens come, all those flowering privet hedge things, the lily pillies, which are one of my enemies. People that suffer with perennial allergic rhinitis, so all year round or non-seasonal, often their allergens are quite different. So they might be more inside things. So that can be allergens to pets is a really common one, or dust mites, or airborne molds, or things like that. So it's just a matter of trying to help people work out when their rhinitis is happening. You can get more of an irritant rhinitis as well, which is a response to chemicals or fumes or strong smells, and that can affect people with these same symptoms. So we try and take a good history about all of those things and the identifiable triggers if we can. We would do a physical assessment, of course, so having a look at the upper airways, the nose, examining the face for the sinus, whether there's swelling or sinus pain. Often people that do have allergic rhinitis have dark circles under their eyes, so they don't feel that great, and you can certainly see that they're a bit congested in their upper airways there. That transverse nasal crease, this is the picture here of that constant wiping of the nose, so they get that little sort of crease there. There can be coexistent allergic conditions, and as I've talked about, it's very common with asthma, but also can be eczema as well. So in the Australian Asthma Handbook, and I hope you're very familiar with that, there's under clinical issues as the heading, there's a section there on allergic rhinitis, just to point you out to that website. So to diagnose allergic rhinitis, we would be doing skin prick allergy testing, and that is the most common test probably, and perhaps the most, or the what we would call the gold standard diagnostic test for allergic rhinitis or allergies. And the reason for that is because the allergens can be very specific. So there are a large range of allergens available for specialists to access, and you can go right down to different types of grasses or different types of plants, and that's a little less easy to do with the RAST testing or the serum specific IgE test. That is available, of course, now. The limitations of the tests we need to remember is that those positive results don't prove that the allergens are causing the symptoms. It's another piece in the puzzle, and it certainly identifies to us that that person has allergens, and we need to keep that in mind, but they would be something to remember. The tests that are not useful are food allergy testing. There's not a strong correlation between food allergies and rhinitis necessarily, so we wouldn't always be leaping to food allergy testing. Total FBE and total IgE is not of much clinical use. It just would tell us that there's inflammation. It's not telling us much else. And then there's those less proven testing methods, kinesiology, reflexology, or hair analysis, for example, and we would be not encouraging people to have those tests done. So now to get skin prick allergy testing, that would be available through an allergy specialist or an allergy clinic generally. So our treatment range for allergic rhinitis are wide and varied, and we've got lots of them, and I'm sure you'd be familiar that if you went into the local pharmacy, you know, there's probably a whole aisle of a row of allergy treatments, which is excellent. But as I said, it does mean that sometimes people go in and purchase something or other, and it's not giving them the most optimal treatment that we might be wanting them to have. And part of that can be because consumers really need to understand that we're treating an inflammatory condition exactly the same as we are with asthma. So we do want to be looking for those things that are helping to reduce inflammation as well as helping to reduce the symptoms of the inflammation, the rhinitis and the watery eyes, etc. So at the top of the list are the intranasal corticosteroid nasal sprays. These are widely available now. Some of them are over the counter, some of them are scripted products, and they work directly on that epithelial lining and they reduce the inflammation. They do have side effects for some people, so it's important with any of our devices that people receive correct device technique training so that it minimises the risk of side effects and also increases the efficacy of the dose of medication they're actually getting. We can get antihistamine nasal sprays, which don't treat inflammation but do reduce the symptoms of the condition. And we can get combination sprays that have got both of those components, so the corticosteroid and the antihistamine in one spray. We can also get, which actually I've just realised isn't on the slide, we can get saline nasal sprays. So excuse me a second and I'll just note that down for myself. Saline nasal sprays are available as well, and that's simply working as a wash. We can get the rapid-acting oral antihistamines, non-drowsy, so there's a range of those products available, as I'm sure you'd be aware, that people can take in tablet or liquid form. Oh, I have got saline there. I've got it as a saline sinus rinse. So you can get that in a spray bottle, or you can actually get it as a full bottle rinse, which is a little more aggressive, not a particularly pleasant technique to do for yourself, but those people that do use sinus rinses really say that they give them a lot of benefit and help to keep their sinus passages nice and clear, which is good. We can, if we can confirm the allergen, then we can give people self-management information about reducing their exposure to the allergen and hopefully avoiding the allergen. That's not always possible for people. Just think of dust, for an example. If that's your allergen in our windy days, as I said, it's almost impossible to reduce your exposure to that unless you're going to stay indoors on those days. We can have specific allergy immunotherapy desensitization, and that can be sublingual or subcutaneously administered. That's through an allergy specialist as well. That's the only treatment of all these ones that I'm talking about that actually can modify the immune response for someone. It is a range of therapy that needs to be discussed and understood because it's quite a long-term thing. A couple of years of treatment is involved usually for people, but it can be really life-changing for those people that helps. Oral corticosteroids should be avoided. So that's not a type of medication that we would want to be using for normal allergic rhinitis treatment, may be used in specialist rooms perhaps for really severe times, but it's not something that we would be promoting in our primary care settings. And just a reminder that there are how-to videos available on the National Asthma Council website which demonstrate the correct technique for using nasal sprays, sinus rinses and any of the inhaled medications. So they're free and readily available for you. So just having a look at treatment plans now, and these are also available. The one on the left, the treatment plan flowchart, is available on the in the asthma handbook, and the treatment rhinitis plan there is available on the ASCIA website there, allergy.org.au. So this would be a flowchart. It's really helpful if we're thinking about where do I start treatment, what am I going to do about treatment, and I'm not a prescriber, so I'm not going to, tell you what to what to use or what to prescribe. I'm here tonight to just talk about the range of treatments available. But just briefly, if the symptoms are mild and intermittent, then might start with an oral antihistamine perhaps, and if after a couple of weeks that's not working or that's not enough, then you would move to the intranasal corticosteroid spray. But in the more moderate to severe, you would start with the intranasal corticosteroid spray and then add on from there. So those charts, as I said, are readily available, and you can have a look at that. The resource list for all of these is available on the last slide of my presentation tonight, and you will be emailed a resource list after the presentation as well. So this is a chart that is available on the NAC website as well, just visually showing you the allergic rhinitis treatments that are available. It's very difficult to keep these posters up to date, so there are other sprays and treatments available now, but it's just to give you a good overview of what's available so that you can talk to your patients about it and show them. There are different devices, so some of the sprays are spray bottles. One, that Avamys there is a squeezy one if people need a different type of device. So just to highlight those for you. So we're treating away, but people aren't responding the way we thought they would be. And very similar to any other condition, I guess, in primary care, then we would consider referring on for people with allergic rhinitis. If there's no response to the treatment, or if there's limited response, or if you feel that that person hasn't responded the way that you would appreciate, or they're not getting relief the way that they actually want, then good time to refer on to a specialist. That would normally be an allergy specialist, but it may be an ENT specialist if there's other complicating factors going on there. So the other thing to consider about allergic rhinitis, if the allergic rhinitis is less well controlled than we would appreciate, and that person also has asthma, those two conditions the control of those two conditions can affect each other. So poor allergic rhinitis control can lead to poorer asthma control as well, despite their regular preventer medication. So we certainly don't want that occurring at any time of year, but we certainly don't want it at springtime. So that could be another reason to refer on and consider really sorting the allergic rhinitis out, so that we're aiming to improve the asthma control as well. You'd also consider referral if there's other allergic conditions present, so such as the severe asthma severe eczema, beg your pardon. If there was food or other occupational type allergies suspected, it was a bit more complicated than a straightforward allergic rhinitis case. And as I said, considering an ENT specialist if there's resistant obstruction, that might be a polyp or something like that, loss of smell, what else, like unilateral obstruction, snorers, people like that, they might benefit from an ENT referral. And as I said to you, the specialists can contemplate or offer the immunotherapy. So that's really, as I said, really life-changing for people if that's something that's worthwhile. So there's a nice little overview about allergic rhinitis. And Marie, I'll just stop there for a minute and check with you if there's any questions about that.
Thank you, Mark. No, I haven't seen any questions come in as yet, Jen.
All
no,
good?
not just yeah.
All right, terrific. So I'll continue on with my presentation on thunderstorm asthma. So thunderstorm asthma, I'm sure you probably all remember, or those of you that would have been working in primary care in November 2016, there was really quite a catastrophic thunderstorm asthma event here in Melbourne. And after that, we really started to talk more about thunderstorm asthma, but it has been around longer. So there's a couple of definitions of it here, and I'll just read them out for you. So the first one is an observed increase in acute bronchospasm cases following the occurrence of a thunderstorm in a local vicinity. And then an unusual cluster of allergic asthma flare-ups, including severe acute asthma associated with some types of thunderstorms in spring or early summer. And that second one is slightly more descriptive because in thunderstorm asthma, we've got this combination of allergic component, and it's not all thunderstorms, and it does most likely or most commonly occur in spring and summer. So just a couple of varieties there for you. So this slide comes from Frank Tian of Eastern Health, and we thank Frank for that. But I really just like to point this out. So the very dramatic event right there down the bottom, November 21-22 in 2016, as I said, very hot day in Melbourne. This massive storm came over at 6 o'clock at night, and then the ramifications of that just cascaded very, very quickly. But the result was that about 3,500 people presented to emergency departments. This is within Greater Melbourne, and 35 ICU admissions, and very sadly 10 deaths. So that event was very dramatic. But if you look back up the slide from there, you will notice that there's quite a history of thunderstorm asthma events in Melbourne. 211, 210, 23, 89, 87, 84 are the ones I've got stats for. They had caused increased presentations to emergency departments before, increased admissions, ICU presentations, and 1 death. But what I think is really worth pointing out is they all occurred in Melbourne in November. So it's really timely that we're talking about this in October so that we can get prepared. Hopefully it doesn't happen every year, and we've been lucky in the last few years, but this is the time of year that we need to be getting ready. Although we've got Melbourne stats there have been other episodes in Australia, so Tamworth, Wagga, Newcastle and Canberra, and there's some events that have been documented internationally as well. So these stats come from DHHS, and in that 30 hours after 6 o'clock on the 21st of November leading into the 22nd, these just talking about the massive increases to presentations. So 672% increase for the number of people presenting into an emergency department in a 30-hour period, and a 900% increase, or nearly 1,000% increase in admissions for asthma in that same period, which is just really completely overwhelming for the medical services. It overwhelmed the Metropolitan Ambulance Service. It was very difficult for healthcare providers, and very, very frightening for the community. And I can remember that in my practices that I was working in at that time, after that, I was just fully booked for months and months and months, which was great because a lot of people were really, sort of given that jolt to come and make sure that their asthma was reviewed and that we sorted it out. There were, of course, many stories of extraordinary care from community service and primary healthcare providers over on that night as well, which is, really needs to be remembered and acknowledged. So, as I said, not all thunderstorms. What do we need for a springtime event? So there is a full report about that thunderstorm event, which once again is on my resources for you. It's the state government review of the response to the thunderstorm event in November 2016, and the final report was presented in 2017, and this is where this information comes from. So it's a springtime phenomenon. It requires high concentrations of allergic material, and usually in Victoria that is ryegrass pollen. That's what they've determined that to be. And I know that the event that was documented in Wagga, also they actually had pollen counters up in Wagga at that time, and that did identify ryegrass pollen as being the main allergen for that event as well. But it could be fungi or dust or other very small particles. It requires a thunderstorm outflow, and I'll explain what that means in a following slide. the pollen needs to be in respirable sized particles, which are very, very tiny, much smaller than normal pollen. And I'll explain how that occurs as well. And then, of course, people are exposed to it. And this is why when we talk about the type of thunderstorm, it'll make more sense for you, but also the time of day that these storms occur. So in November 2016, that was at 6 o'clock at night after a very, very hot day in Melbourne. So there were a lot of people outside. But, you know, if a thunderstorm was to occur at, say, 2 a.m. in the morning, there may not be so many people exposed, which is a good thing. The map there is just showing you data from 2016, which indicates the high rainfall that the Western District of Victoria had that year, which produced a lot of grass, and that was part of the reason that there was a lot of ryegrass pollen on that particular year. This year, the Bureau of Meteorology have just announced the La Nina effect, which also will give us high spring rainfall, just to be aware of that. So talking about the type of thunderstorm, this is a visual representation of the hypothesis for the mechanism of what happens in thunderstorm asthma. So as I said, we need a high pollen count day, and we're very fortunate that we do have pollen count monitors. So we now that comes out on apps, that comes out on often the news. Certainly there's lots of social media that you can look at to find out your pollen counts on any particular day. But so we need a high pollen count, and that pollen is swept up into the moisture of the storm. So it goes up into the storm where it is the moisture ruptures the pollen into tiny, tiny respirable pieces, and my next slide will demonstrate that for you. And then as the storm and the air movement in the storm occurs, we've got that downdraft of the storm with the wind, and the wind coming ahead of the rain brings that tiny respirable pollen granules right down to the ground, and that allows people to inhale them right down into their lungs. Normally larger pollen molecules would be filtered perhaps by the nose when they're larger, but these go right down. So that's that outflow that I was talking about that brings it right down to the ground. So I'll just, hopefully this will work. This shows us a little video. Oh, no. Ah, here we are. This shows us a video of what happens to the pollens when they absorb the moisture. Well, I'm not sure why, but I tested that today, but I'm not sure why that isn't actually working. It just shows some of those grains of pollen rupturing. I'll see if I can click on it, if it'll work. Well, I'm so sorry about that. I'll have to write that down as well, that didn't work. Anyway, I'll bring your attention to over here, which has actually got some of them ruptured. So these large ones are the grains of pollen when they're large, and these are the ones that have been affected by moisture, and they will rupture into those tiny, tiny little particles there. So if this video was working, these ones explode and you see these rupturing. I actually saw this in person one year. I was riding my bike along some roads out near Horsham, and I looked across the grass and you could see, I didn't know what it was. I didn't know it was pollen, but I could see like little clouds of, I want to say white, but it was sort of not like clear air. It was, you could see it was little clouds of something above the paddocks. It was early in the morning and I didn't know what that was. And then later, I was speaking to some locals and they said, oh, that's actually the pollen, the grass pollen that you could see. And I found that fascinating, and I'd never actually seen it before. And I had a colleague recently that I was working on this very presentation with, and he sent me a photo of a golf course from down in Tasmania, and that showed the same, a cloud of sort of pollen above the grass, which is really interesting if you do get to see it. So I do apologise that that didn't work. I'll have to get on to that. So when we're talking about thunderstorm asthma, we need to consider those that are at risk. What are we going to do about this enormous number of people that can potentially be affected? So those most at risk are those with a sensitisation to ryegrass pollen, and they may or may not know that. So they might have hay fever, but they don't necessarily know it's ryegrass pollen, although in Victoria, we can assume that a lot of people are very sensitive to ryegrass. It's one of our major allergens here. They may already have hay fever or with or without asthma. They may have asthma. They're especially at risk if their asthma is poorly controlled. So we need to be working with those group. The people with asthma that are not taking regular inhaled corticosteroid preventer are more at risk at thunderstorm asthma season as well. And then, as I said before, to be at risk, you're exposed to that open air before and during a thunderstorm in the pollen season, or people living in the high pollen count areas, particularly in southeastern Australia. So we've essentially got 4 groups to manage: those that have got asthma, those that have ever had asthma who may not feel that they're suffering from it at the moment, those with seasonal allergic rhinitis and no asthma, and the rest of the community, no allergic rhinitis, no asthma, those lucky ones that spring doesn't seem to affect too much. So the risk group for the ones that have got current asthma, you're probably very aware that the Australian Asthma Handbook guidelines have very recently been updated, just in September of this year. Version 2.1 of the guidelines was launched, and the major change for those guidelines was that most people and those with mild asthma are now recommended to be on inhaled corticosteroid preventer therapy. So we've got some choices of the types of medications we would use there, but for anyone with current asthma, even in the mild asthma group, now we would be treating with preventer therapy, and we would be particularly treating them over springtime and making sure that they're taking it as you've prescribed it. We want to ensure that these people are using their inhalers correctly, so we wanted the maximum dose of medication to be getting down there into their airways and their asthma to be very well controlled. And check that they're actually taking those preventer therapies as you've prescribed. So usually that would be daily, sometimes twice daily for some medications, and now we have the option of Symbicort taken as needed for those in the mild group. Anyone with asthma should be always carrying a reliever or have access to reliever, and that can be short-acting beta-2 agonists, usually Ventolin or Bricanol, or now can be the anti-inflammatory reliever, the Symbicort reliever therapy for the mild group. They need to have a current written asthma action plan that makes sense to them and that they understand and that they know how to use. We need to review people with asthma for allergic rhinitis. So remember that percentage, 50 to 80% of those with allergic rhinitis also have asthma. So we need to be asking them about their hay fever, not just about their asthma control, but ask about their allergic rhinitis control and treating them over springtime. And then talking to them about lifestyle management types of things. So being aware of the high pollen count days, being aware of if a thunderstorm is predicted, avoiding outdoor exposure if those two things are coming together on the same day. If they're at home or in the car, they can close the windows and use recirculated air on high pollen days or during the thunderstorm. So just really trying to help them to limit that exposure. The risk group of any history of asthma. So as I said now, we've got really great guidelines there for people with asthma, but those with any history of asthma, you know, asthma is one of those conditions where people can mistakenly believe that they've outgrown it or it's not affecting them at that particular point in time. They feel well, so they stop all their treatment. But specifically, if they've had history of asthma, we would need to be doing an assessment of how that is for them at that moment. So whether they have allergies, whether they have seasonal symptoms, how long it's been since they experienced asthma symptoms, the severity of that previous asthma, if they've ever been in hospital with asthma, if they were affected in previous thunderstorm events, then it would be sensible to consider prescribing low-dose inhaled corticosteroids over the pollen season for them, talking to them about their risks and encouraging them to be prepared. Would certainly be reviewing for allergic rhinitis as well, and treat them for allergic rhinitis over pollen season as well, if that's something that they suffer from. But for those that we think perhaps don't need the corticosteroid therapy, then you would be really wanting to concentrate and talk to them about making sure they would recognise if their asthma recurred, talk to them about the symptoms they did experience, if they knew what triggers they were, and make sure that they would understand what to do. So providing them with an action plan, explain to them when to increase their medications or commence medications, talk to them about carrying a reliever, knowing how to use it and making sure they know how to use that device correctly. And the same lifestyle issues that we talked about, avoiding exposure on those dangerous days. So the risk group that have got allergic rhinitis and no asthma, then we would be, of course, managing their allergic rhinitis, as I said in my earlier presentation, and making sure that they're on treatment. And the treatment of choice would be the intranasal corticosteroid sprays, commencing now so that they've got some cover and staying on it throughout the pollen season. If they're travelling to high pollen areas, so not with COVID right at the moment, but you know, some people would be perhaps coming from interstate where they wouldn't normally have that as a trigger for them, or in their home they may not. But if they're coming to high risk pollen areas, then they might be wanting to have their allergic rhinitis treatment nice and handy as well. I know when I travel to Central Australia for any reason, I go with my little armoury of hay fever treatment, because don't know what it is up there, whether it's the dust or whatever, but something affects me badly in the Alice Springs area. So we would be talking to this group about recognising asthma once again. Would they understand if they were getting asthma? These people don't have asthma. So we just need to have a little discussion. If you experience symptoms, or respiratory symptoms with your allergic rhinitis, then you need to come to your doctor and talk about that and make sure that we know what to do. They need to know how to get a reliever, that they can buy that over the counter. If they needed to use it, that their device technique is correct, and that they are aware of asthma first aid, because that could save a life. And certainly in November 2016, people were aware of asthma first aid and really helped each other in the community. And then the same, minimising exposure on the pollen count days and if thunderstorms are predicted, and using the recirculated air. That message is on every slide, you'll notice. So the risk group with non-seasonal allergic rhinitis, no seasonal allergic rhinitis, I beg your pardon, and no asthma, we need to really reassure them that their risk is quite low. And look, it's interesting, isn't it? Because people do forget. It's 4 years ago. Those of us in health services will probably never forget that thunderstorm asthma night. I don't think I will. And I'm sure there's others in that same boat as me, but the community do forget. But those that were afraid or were affected, had a family member or experienced, watched something happen to someone, can certainly have a level of anxiety about thunderstorm asthma. So we need to reassure them that their risk is quite low, and the best thing that they can do is understand asthma first aid so that they can help others if they need to. So we've got community first aid posters available from National Asthma Council as well, one for children, one for adults, and you would probably all be very familiar with this, or I hope you are. And it's often called asthma 4x4x4, and the reason for that is because of the protocol that we use. We administer 4 individual puffs of short-acting beta-2 agonists, usually Ventolin, via a spacer. Take 4 breaths per puff, so it's 1 puff into the spacer, 4 breaths, do that for 4 puffs, and wait 4 minutes. sit that person upright, keep them calm, stay with them, talk to them, monitor their breathing, monitor their symptoms. If after the first 4 minutes the symptoms are persisting or getting worse, then you repeat the steps 1 to 3. If there's no improvement, then you're dialing 000 and getting some emergency help and continue to administer the Ventolin until help arrives. You can, of course, use Bricanol if that's the reliever therapy available, and that's the turbohaler dose of 1 dose at a time. And you can use Symbicort in asthma first aid now as well, because the formoterol in the Symbicort has the same rapid onset as the short-acting beta-2 agonists. So just a little view there. Now, I just wanted to spend the last few minutes of our presentation talking about preparing for thunderstorm asthma season. So we've talked about allergic rhinitis. We've not touched on asthma too much because we're not talking about asthma specifically, other than what occurs and how that occurs with thunderstorms. So we haven't covered asthma treatment as such, but it's about being prepared for springtime thunderstorm asthma season. How do we actually do that in our workplaces or for our people? So it's an absolutely wonderful time now to be providing that essential asthma review for our patients. And at the moment, we might be needing to do that via telehealth, but we would be really trying to proactively review people and making sure that they've got optimal asthma control. They're using their regular preventive therapy as prescribed, and they have a reliever available. We'd be checking the correct device technique and adherence to their medications. We're optimising their allergic rhinitis control as well. So 2 prongs of treatment there if we need it. And usually over spring, that's the regular intranasal corticosteroid sprays, as I've talked about. Make sure everybody's got a written asthma action plan. Everyone with asthma should have an action plan anyway, but we know we don't always do as well in that area. But also making sure that it's understood and it makes sense to them. We want to promote and educate people about asthma first aid, and then those lifestyle education that we've talked about, knowing where to access pollen count readings, weather event warnings, avoiding that outdoor exposure, closing windows, using recirculated air. So written asthma action plans, coming back to those, super important. There's many versions available there. Of course, I've put a picture of the NAC one there, but they're available through all the practice softwares. They're available through other asthma organisations like Asthma Australia. So NAC has an action plan library on its website that you can download these from. I always try to just get that message across that action plans are much more than a piece of paper. They can actually be life-saving advice that you're giving people when you talk about an asthma action plan. So always remember that. Asthma plans improve asthma outcome by improving asthma control. So people take ownership of their symptoms, they understand their own symptoms, they know the treatment plan, they know what to do when their symptoms are worsening, and they know how to adjust their medication accordingly. And that's just so important. Action plans also remind people when to see the doctor, because one of the things that happens out there in the community is that people wait too long. They tolerate those symptoms too long. They need to know when they really should be proactive and get to their doctor, and also when to call an ambulance. And there's a lot of people in our community that would say, oh, I'd be really reluctant to call an ambulance. I don't think I'm that sick. So that's another topic of conversation with asthma. Asthma flare-ups and attacks can occur very, very quickly and progress very, very quickly, and people need to feel very confident that they can call an ambulance, of course. So, advice for our at-risk patient groups. I think we've covered all this really. I don't think there's anything different on that slide in terms of thunderstorm asthma, making sure that they've got their reliever medication, whatever that is, making sure they're taking their preventer. Correct technique, I think we've talked about everything on that slide. Our thoughts to consider in terms of in your clinic, prepare early. As I've said, really good time to proactively review those with asthma now, or anyone with allergies, or anyone that you know that was affected with the thunderstorm asthma event in the past. Be aware yourselves of the high pollen days in the thunderstorm weather forecasts, because you might get an influx of people suffering with rhinitis or asthma or both. Make sure you've got some bronchodilators in the practice that are in date and a supply of spacers, and that you've got a policy or that you've talked about how you're managing people that present into the practice with asthma symptoms, and that includes all staff. There's a triaging process for medical receptionists. There's a process of treatment for practice nurses and GPs, so that everyone knows their role if someone presents into your clinic way more ill than you would be expecting. It's a really good opportunity to train all staff in asthma first aid and have a first aid chart on display, and that can even just be in the waiting room. You know, while people are waiting and staring around, they can have a look at that. As I've said, we may need to use telehealth for the reviews at this actual time of year during COVID. In the pharmacy, we would want to make sure that there's adequate supply of asthma medications, of course, and an adequate supply of spaces, because hopefully more people will be prepared and be coming in for these. There's a pharmacy flowchart available on the NAC website as well, which helps to organise the treatment and the workplace preparation for allergic rhinitis in particular. Once again, it's really an opportunity to talk about people that present into the pharmacy with symptoms. Make sure that the pharmacy assistants and the pharmacists themselves know their responsibility and how to prioritise these patients, and talk to them about their rhinitis and their asthma. And training all staff in asthma first aid and having a chart available. Know which GP clinics are open and open after hours and might be able to assist if that's appropriate, and opening up that conversation if patients are requesting rhinitis medications, asking them about asthma, asking them about their control, and recommending that they see a GP if that's something that you think is required for them. So just to put it out there, does your clinic workplace have an emergency asthma plan policy? Who is responsible for the different aspects of care? What would you do if you know, you were the only receptionist or nurse in the practice, or the only GP in the practice? How would you manage all that? Is there a consistent approach to emergency asthma management? Does everyone know where the reliever is? There's lots of information there available for you in the asthma handbook to help with that. So in summary, be proactive in spring. Let's don't wait for something to happen. May or may not have a thunderstorm event, but let's be prepared. Really good time to review everyone with asthma and allergies, as I've said, talking about medications, talking about lifestyle management. Great time to push the asthma action plans and really look at that, and raising awareness of asthma first aid for everyone. I did want to just point out that if you don't have access to an asthma educator in your own practice or workplace, that Asthma Australia has a community educator program, the coach program, which is a free 1-800 number, 1-800-ASTHMA, 1-800-278-462. That's worthwhile. And just to summarise a little bit about asthma and COVID, because we can't have any presentations at the moment without thinking about COVID, which is ruling our lives. On the Australian Handbook website, there is information there about managing people with asthma during COVID. So check everyone with asthma has a current action plan, and as I said, that can be telehealth if need be. In Victoria, we're not performing spirometry in primary care at the moment. It's being performed only under respiratory physician recommendation, and only those people that urgently require it. Advise everyone with asthma to continue with their asthma medications. Of course, only using oral steroids for flare-ups as indicated. Excellent opportunity to reduce nebulizer use or not use it at all for aerosol containment. So well-fitting mask and spacer is preferred. Remind everyone not to share any medications or spacers as well. And just to finish up, to ask you that question is, how would we manage a thunderstorm asthma emergency event during COVID? So we would be thinking about presentations, mass presentations into our workplace. How are we going to manage these people? There's a little question for you as you enjoy your dinner after tonight's presentation. So I think we've timed that beautifully. This is just, as I said, some resources that are available. Everything's online for you. The handbook's freely available. NAC website has many resources for you. Asthma Australia has community-based, consumer-based resources, and the ASCII Allergy website is a fascinating website if allergic rhinitis and allergy is your topic. So thank you very much for your presence tonight and listening to my presentation, and we'll just have a few minutes left for any questions.
Thank you very much. Excellent. Thank you very much, Mark. That was a fabulous and timely overview, and there are quite a few questions coming through. I will try and manage reading them, and I hope you're not getting any feedback there, Jen. I'm getting a little bit of echo, but I'll persist and I'll wait if you send me a message if it's not coming through clearly. Mark, the first question, I think, and you touched on it just then, is how are asthma and seasonal rhinitis complicated by COVID? And I think your answer there was be prepared, I suppose, because it will be very complicated in an emergency and rushed situation. But do you have anything else that you wanted to add there?
Oh, look, I think you know, those out there in the workforce are probably you know, even better equipped than I am to think about that question. But I think the overriding thing we need to remember is that presentations to our primary care providers at the moment, be that with respiratory symptoms, breathlessness, cough, runny nose, sore throat, those types of things that are all over the media, we need to be aware that we've got COVID here. So we need to be making sure if they're patients that have asthma or patients that are well known to you, then you may triage them differently. But if they're presenting with those symptoms, we have to think of COVID first, and people would be tested or, you know, asked to attend a COVID clinic for a COVID test. But I think it's quite you know, challenging to think about a thunderstorm asthma event happening during COVID, because it's going to be a big decision for us all. What are we going to do? We have to provide emergency asthma treatment, but we'd have to be trying to do that remembering our treatment guidelines for COVID as well.
Thank you, Mark. There's a few questions, so I will jump into the next one. Since nebulizers are not recommended at this time, what is the pathway for treating thunderstorm asthma in the primary care setting during the pandemic? And thank you to Denise there for that question.
So that would be where we would be applying, if you look in the asthma handbook, you would know that there's charts for acute asthma management, and we would be using metered dose inhaler Ventolin with a spacer in adults, 6 to 12 puffs, to treat acute asthma rather than giving nebulized Ventolin. And that's actually been around for a long time, those guidelines. So please go to the asthma handbook under acute asthma, and you'll see there that nebulized Ventolin is really only reserved for emergency department presentation or really severe flare-up.
Thank you. And a question from Amy, how long do you shake the Ventolin between each dose?
Oh, look, isn't that an interesting question? Because we all try to do this so well, and you know, you sort of get into that habit of just a good little shake. I guess the thing to remember is the device needs to be held nice and upright, and the reason we're shaking metered dose inhalers is because there's propellant and medication in there, and they need to be mixed together so that when you actually press, you get a nice you know, a full dose of medication there. So I guess, I'm trying to do it, I guess it's like a maybe 5 or 10 second shake where you're just giving it a good firm shake up and down, shake up and down. Just a few seconds really to make sure that you're mixing the components in the puffer.
Excellent. And from Danny, thank you. There's it's really more of a comment, but I'll get you to comment on it too. Epidemic thunderstorm asthma forecast on the Vic emergency site. So is that a good place to steer patients to?
Yes,
Yeah.
and I'm sorry, I should have mentioned that during my presentation, but yes, we've got the pollen count website, Melbourne pollen count, and we've got the Vic emergency website, which will alert people to thunderstorm events, and they are readily available for people to have on their phones. You know, you can get alerts for when these things are forecast. Thank you, Danny, for pointing that out.
Excellent. And from Jennifer, how would you advise on using a mask during the pandemic with asthma or allergic rhinitis? Yeah, that's really.
Once again, this is where the complexity of COVID rules our world at the moment. Masks are compulsory if we're outside, and you know, people talk about medical reasons for not wearing a mask, and my personal opinion is that we need to be protecting ourselves and our community from COVID, and we should be trying to wear a mask if at all possible. So if you've got respiratory symptoms, then perhaps it's best to stay indoors for you if you're not feeling well enough to be out with your mask on.
Excellent. And there's a great comment here from Robin. I'll just scroll up a little bit. Remembering to have enough PPE to wear for treating anyone with acute asthma. Yeah, that's going to have to be a very real consideration, isn't it? Yeah.
That's right. And yeah, this is where I say that you coalface workers out there are really the ones that are fully aware of what's going on in your practices at the moment in terms of PPE and COVID precautions.
And there's another question there before it runs away from me up the which is the app for the pollen count?
Melbourne pollen count, I think it's called.
Okay.
That's actually a website, and I do believe you can get that as an app as well.
Okay, and for spaces and ventilator and puffer from Jessica here, would these be single use only during the pandemic?
For emergency care, I'm presuming that means?
Yeah, I imagine Jessica's meaning for emergency presentation. Yeah, yes.
Well, I think these days most practices would have a supply of either single-use spaces or autoclavable spaces, but it needs to be certainly only used for one person. Yes, each space is used for one person. But this is why we always encourage people to have their own. This is a time to talk to people about their devices and how they use them, and make sure that they've got their own puffer and spacer with them.
And this is a great question. Thanks, Mark. From Laura, are community asthma programs still offering home visits during COVID? Do you know if they're...
I don't know the answer to that. I'm sorry. I could take that one on notice and do some investigating and try and get back. I don't actually know the answer to that question. I do apologise.
All right. Now, there's a very warm hello, Mark, from Louise Fox. Thank you for the presentation. What are your thoughts with Aeromere auto inhalers, especially children, for children 8 years and above?
Is the question about whether they can use them?
What are your thoughts with the Aeromere auto inhalers, especially I think for children 8 years and above?
Okay.
Yes, she's just clarified yes, whether they can use them.
Oh, thanks, Jen. Or whether they can use them.
Look, technically, yes, they can be used, most children, but look, personally in my practice, I would always prefer that these are a breath activated device for those that may not be familiar with them. they're not that common. So that's a breath activated device. So you need to be able to make sure that that person can take a nice deep inhalation. So I think it's safer with kids to teach them metered dose inhaler, puffer and spacer. I think then we can be very, very confident that we know they're getting the dose that we want them to take. So my personal, once again, this is a personal preference for me, that I would be wanting the kids that I see to be having metered dose inhaler and spacer in preference. But technically, I guess an 8-year-old could use an autohaler if you could teach them the device very carefully.
Fabulous. I'll start running through them because there's quite a lot
I
and they're all
just
brilliant.
wanted to jump in, Marie. Sorry, we've just had someone else. Thank you, Emma, has actually just responded about the community asthma program, saying they're offering telehealth appointments for families at the moment for children with asthma.
Oh, thank you for answering. Thank you, Emma. I'm really pleased you know the answer.
Yeah, that's brilliant. Thanks, Emma. So I'll go on quick speed. All right. From Amy, do you use any apps for patient education?
Well, I do face-to-face education in my clinics. I'm not actually working in the clinic at the moment during COVID, but normally my education is face-to-face. But I certainly use online resources. So, you know, for example, the how-to videos, those types of things. There's many resources available for people now that can be really helpful as part of your education program.
Fabulous. And Areza would like to know, do you think masks will protect us from pollen? Good question.
It is a good question, isn't it? I think some types of masks perhaps would, you know, the more advanced types of masks, the N95 ones, but most people that I see when I'm walking around in the community are wearing their fabric style masks. So pollen granules are fairly largish. They might help, they might not. At the moment, they're compulsory, so I figure we've got to wear them regardless.
Yes. And there's a question here. Any options for single-use spaces, and where does anybody know where you can buy them? That's Navdeep. Thank you, Navdeep.
There are a variety of single-use spaces available now. There's some of the cardboard style ones. There's some of the polypropylene style ones that are really very cost efficient. So I'd suggest you talk to your medical suppliers about that. There's quite a variety of single-use spaces available now.
Fabulous. And from Elizabeth, this is a great question. How can nurses contribute to the asthma action plan?
That is a good question, because nurses can't prescribe unless they're nurse practitioners. Nurses can't prescribe medications, of course, but I see the role as that you can, if the GP needs, you can help them draft it up, and then it's the GP responsibility to actually make sure that it's signed off with them and discussed with them. But if it comes the other way around, that the GP's done the action plan, then the nurse role can be in really explaining that to the patient, making sure that they understand it, making sure it's in a language that they understand, that at their level of health literacy, making sure they've got copies for carers or schools or kinders as they might need. And even in just promoting, you know, asking everyone they see with asthma, do you have an action plan? If not, please talk to your doctor, please ask for one.
Fabulous. And there is a comment from Jessica. We're going to wind up with the last, this is the second last, but I think this is important. There's ped asthma educators at DPV Health covering North and West Melbourne, and they are doing education sessions through telehealth. So if that's fabulous. Thank you, Jessica, for sharing that. And then this is really important. I am somewhat confused from Roland. You say asthma first aid, use 1 puff every 4 minutes through the spacer, but in severe asthma, we should use 6 to 12 puffs when does one decide how many puffs to use, Marg? That's a curly
So
one, but it's important.
Yeah, asthma first aid is the 4x4x4. So it's actually 4 puffs, one at a time is what I said. So I don't want people going 1, 2, 3, 4 puffs into the spacer. It's 1 puff, 4 breaths, 1 puff, 4 breaths, 1 puff, 4 breaths, 1 puff, 4 breaths. So that's 4 doses of medication each 4 minutes. That's asthma first aid. That's community first aid. In an asthma action plan or in a healthcare setting for acute asthma, you may escalate that up under a different protocol, which would be that person's plan where the reliever therapy is administered differently.
Excellent, excellent. All right, Marg and audience, thank you very, very much for attending tonight. I'd like to say a big hello to a chum who sent me a message, Kerry, so I'm glad that you're in there and listening, and everybody at your surgery as well. So there will be an evaluation survey and feedback opportunity will follow from this. And with that, I think we've run a little bit over time, but Margaret, was a great update. Thank you ever so much, and thank you to Jen in the background there for helping out and jumping in, and for all those fabulous audience members who popped in questions. Thank you very much.
Thanks, everyone. Good night.
Good night.